Okay, so for this PowerPoint, we're going to be focusing on structures of the upper airway. So you are not responsible for memorizing this diagram. The reason that I include this is I feel like starting off with this perspective as we move into the more detailed diagrams kind of helps you guys put it into perspective what the structures. So I just want to draw your attention to specifically the hard palate and the soft palate here. This is called your uvula, which I think is good to know. Obviously, you guys are familiar with the tongue and the lips, but just kind of looking down through the mouth, and then this is kind of where it gets a little bit more detailed. So, kind of seeing that first perspective to guide you into this diagram, I hope will help you stay oriented to what we're talking about. So, the first areas I would really like you guys to take note of is we are going to be memorizing the nasopharynx, oropharynx, and laryngopharynx. So the nasopharynx is comprised of your hard palate and your soft palate, which is just the harder part of the roof of your mouth. And then as you kind of move posteriorly to the back of your mouth, it gets softer, so your soft palate. Your oropharynx is below that, and that has your tonsil and your tongue as part of that. And then your laryngopharynx, which is one that I really want you guys to commit to memory. The laryngopharynx has your epiglottis and your vocal cords. This is going to become a very important area for us as respiratory therapists because we're the staff and part of the team that assist with all the intubations. And we are kind of a second pair of eyes, as well as somebody who's handing the equipment over to the doctor that's doing the intubations, or depending on the situation, we will be doing the intubations ourselves. So as we move through this, unit, you guys are going to see some videos of an actual intubation, and you're going to see these structures in real form and function through a video scope or a Glidescope. And you'll get to see the epiglottis and the vocal cords, which is what the intubation or the breathing tube that we put in actually passes through. So nasopharynx, oropharynx, laryngopharynx, and then the structures that are within those areas. The other thing I want to draw your attention to is if you can locate down here the esophagus and the trachea, you'll notice that the esophagus and the trachea basically lie on top of each other, the trachea lying on top of the esophagus, with a fairly thin barrier in between them. The reason that this is really important to note is when you are trying to place a breathing tube, it is very easy for that tube to go posteriorly into the esophagus, which would mean that you have now placed a breathing tube into a patient's stomach. So the trachea is just slightly anterior to the esophagus. And one of the things that we do right away after placing a breathing tube is ensure that it is in fact in the lungs via the trachea versus the stomach, because it can be such an easy thing to get into the esophagus. Again, if you look here, it is right next to the trachea, thin divider here. So really making sure that that breathing tube comes up anteriorly, goes into the trachea, and that you actually have the breathing tube going to the lungs. The last thing on this diagram that I think is very important to note is what is called the cricoid cartilage, which is located right here. And the reason I want to point that out and I want you guys to memorize where that's located and what that's called is it's essentially where you would locate an Adam's apple in location, and physicians will often ask for cricoid pressure when they're trying to place a breathing tube. And the reason that they do that is they just want us to take our fingers and gently push on that cricoid cartilage, and it kind of pushes that trachea back so that it becomes more of a straight line and creates a little bit of resistance so that they are more able to get that breathing tube in. So cricoid cartilage, the physician will ask you for cricoid pressure, which is just pushing down on that cartilage, is the other thing that I want you to really locate on this diagram. That's it for this diagram as far as the structures. If I didn't mention it, you don't have to worry about it. This is another diagram that shows the same things. Again, I really do like to do more than one diagram to illustrate the structures that I think are important. So this again shows you the nasopharynx, oropharynx. They call the laryngopharynx the hypopharynx. You can kind of disregard that verbiage. I will never use that verbiage. So part of the reason that I throw this on here is just so you can see the locations via color, kind of color coordination here, how they have the green, the yellow, and the blue. I apologize if that's confusing. You'll notice as we move through this, respiratory therapists and the powers that be love to have more than one name for things, as if there's not enough flashcards to be made. So this is essentially your laryngopharynx. I will never use the hypopharynx on an exam. You won't be responsible for knowing that other verbiage. So I apologize if that's confusing. This again shows you the esophagus and the trachea. And again, you can see that they are not separated by much. So again, kind of realizing how close those two structures are. Over here, I did a cross section where you can see the trachea with the esophagus behind it. So your esophagus is more posterior, your trachea is more anterior. And again, that trachea is just that pathway into your lungs where we're essentially trying to place a breathing tube, which you guys will see more as we move through the lecture. So when I'm talking about intubation, okay, what I mean by intubation is when a patient is not spontaneously breathing or their breathing is compromised and we're concerned that they cannot ventilate on their own. And there's a lot of reasons that this can happen, guys. This can happen for surgery. This can happen because of sedatives. This can happen because of disease processes, traumas, all kinds of reasons that someone could require a breathing tube. And we will be involved in all of those scenarios. A physician uses what's called a laryngoscope, which is this right here. And they put it into the patient's mouth, being very careful of their teeth. And this blade here is what will kind of move structures out of the way so that they can look down and visualize where they will place a breathing tube. And a breathing tube is a flexible plastic tube that goes down through the patient's mouth, through their nasopharynx, oropharynx, into the laryngopharynx, through their vocal cords into their lungs or their trachea to ventilate their lungs. You guys will have more experience kind of seeing some videos of this as we move on, which I feel like the real videos help you to really visualize what this looks like. But basically, we're placing this tube in through the trachea to ventilate the lungs, and this is going to be the way that we are going to protect that patient's airway and provide them ventilatory support until they can safely breathe on their own. And you guys can kind of follow the pathway in this diagrams and see how that tube would be placed. This balloon down here is called a cuff. And what that does is we fill that with air and it just kind of seals that tube into place. And the tube is called an endotracheal tube. You'll also hear it referred to as an ET tube commonly. That's just the abbreviation. So you can see those structures from the diagrams that we looked at already. This is the epiglottis. The glottis are vocal cords, which is what the tube is traveling through into the trachea, and then that is going to be how we ventilate the lungs. This is just showing that when you're trying to get a breathing tube into a patient, there's kind of an ideal position that you want the head placed in. If you look at these head in the neutral position, it kind of shows you how you have this awkward angle to try to get the tube around into the trachea. Here you have, again, kind of this bend to try to get the tube in. Here's an L-shaped bend. And what they want is they want the head in what's called a sniffing position. And that term specifically, the sniff position or sniffing position, is one you guys should memorize, because basically what it is you tilt the head back just a little bit like you're sniffing the air. That's where it gets its name. And if you look at this subsection here, it shows how that really creates a more straight line for the physician as they're putting the laryngoscope in, or for the respiratory therapist, and it gives you a much more straight line to get that tube into the trachea versus into the esophagus. When you think about wanting to ventilate a patient, trying to get a breathing tube in, you really want that process to be as quick and easy as possible so that the patient isn't going longer than necessary without appropriate ventilation. This is another diagram that you guys are going to want to be responsible for because this is showing kind of like a straight down view. If you could see down the throat past your tongue and your uvula and your soft palate, and you could look down, this is what you'd be seeing through that laryngoscope. You would be seeing this little flap here, and this is your epiglottis. And this is a piece of cartilage whose structure and function is designed to protect the airway. So this is your epiglottis here. It's located above your glottis or your vocal cords, and then through your vocal cords is your trachea into your lungs. So you're kind of looking down through the throat here. This is a very important structure because when you swallow, it moves forward and it covers the opening to your lungs so that things, food, saliva, fluid travel into your esophagus and not into your lungs. If fluid, food, or something other than air gets into your lungs, it's called aspiration or to aspirate. And almost everybody's had that happen. You swallow too fast, food goes down the wrong tube, you immediately cough to try to remove that out of there. We obviously do not want people to be aspirating things into their lungs. It can lead to really bad infections or pneumonias. So the epiglottis is kind of that cartilage that covers it. When you are trying to put a breathing tube in, they actually will kind of lift the epiglottis up and out of the way so that tube can travel through the glottis or through the vocal cords into the trachea. And you will actually get a chance to see this because a lot of the physicians are using what's called Glidescopes, which have cameras associated with them, so you can see the actual process in real time, which is really pretty neat. You guys, when you go into clinicals and you can see this happening, it helps you to really put into perspective the structures that you learned in this class and then how they become relevant in your clinical practice, which is always nice. So this is the same thing, but this is the real structures. So you guys can see it's labeled here. The epiglottis, again, located above your vocal cords. You guys can watch this animation later, like the actual video. But this is just me kind of showing you the same structures with real anatomy so you can get an idea of what that looks like. Again, this is the same diagram with the real structures. You can see this is with the epiglottis down, kind of covering those that opening to the trachea, and then it's getting lifted up and moved out of the way, and then that would be where you put your endotracheal tube into the trachea. So this is what I was talking about before with the Glidescope, and I won't watch this right now during the recording. You guys definitely can watch it on the PowerPoint later, but this is a gentleman who is coming in who needs to be intubated, and this is the camera. You can see the breathing tube going in, and it kind of, again, helps you to put in perspective the structures that we're learning here. I also want you to notice in this video, you can kind of see it for a couple seconds, the patient is very diaphoretic or sweaty and using quite a bit of accessory muscle usage, which we had talked about previously. I'm not sure what this particular patient's situation was, but you can see that from a respiratory standpoint, his work of breathing is elevated, and more than likely he was decompensating, and that's why they decided to put in this breathing tube. So again, you guys can watch that video on your own. And same with this is another kind of animation that shows you that laryngoscope and that tube placement, just so you guys get an idea of what I mean when I'm talking about intubation and why those structures and those landmarks are important.
You may receive endotracheal.
Sorry about that. So again, at the end of every PowerPoint, you guys are going to have lecture questions. I will have a calendar with the due dates for these. I think I'll probably put them in another tab where you know exactly when they're due. You can get the answers for these either from the e-in reading, from the PowerPoint, or from the recordings themselves. If I'm taking the time to put these at the end of a PowerPoint, just know that more than likely they're going to be a chunk of the exam. So really paying attention to these questions is important. If you feel like you can't find the answer, or if you feel like you're struggling with understanding a concept as we move through, feel free to email me and reach out. And that is it